The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. We have done a number of updates on Donald Trump's efforts for better drug pricing and better drug access. We have had additional developments, so I thought we should refresh a bit on what has occurred, and specifically on two topics. One, the administration finally issued its model related to expanding access and lowering price for GLP-1 weight loss drugs in Medicaid and Medicare. And two, we are going to get deeper into the proposed models for most favored nation, MFN, drug pricing in Medicaid and Medicare as well. And after I brief you on that, I will get into the big debate on MFN and pros and cons related to whether we should adopt prospective or retrospective MFN. It is a complex subject, but a good one to cover as we journey toward a new way of setting drug prices, at least in government programs and perhaps for the American healthcare system as a whole over time. We will take 3 breaks today to make this more digestible. Let's get right to it with our first topic, President Trump's commitment to expand GLP-1 weight loss drug access and lower price. True to an earlier announcement, the Trump administration has taken the first steps toward more expansive coverage of GLP-1 weight loss drugs in Medicare and Medicaid. When he came into office, President Trump made the decision not to finalize a proposed rule by the Biden administration that would have expanded coverage for obesity alone in Medicare and Medicaid. At the time, it was the right call. Given GLP-1 prices, expansion could have significantly impacted the finances of the government programs. Well, a great deal has changed since that decision. Trump issued several executive orders to begin to reform drug pricing, including all aspects of the drug channel and introducing most favored nation pricing. After threatening tariffs on brand drugs manufactured abroad, he has struck more than a dozen deals with brand drug makers that lower costs in Medicaid and introduce lower prices for self-pay Americans. These include major deals with GLP-1 drug makers Eli Lilly and Novo Nordisk that reduce net costs in Medicare and Medicaid for GLP-1s. And Trump has embraced Medicare drug price negotiations by negotiating year 2 savings, 25 negotiations to take effect in 27, roughly double what his predecessor did in year 1. Before we get into the model announced by the administration, let's talk about how obesity is a huge problem in the United States. The Centers for Disease Control and Prevention, the CDC, says about 40% of U.S. adults are obese, with that rate impacting both males and females equally. America's health rankings show that over 30% of adults age 65 or older are obese as well. So what do studies say on the use of GLP-1 weight loss drugs? Studies are a bit mixed on long-term clinical outcomes as well as the cost savings overall that these drugs bring. In my mind, there is little doubt that they will help those with diabetes and heart disease better control their conditions. People seem to benefit from both the weight loss effects and other pharmacological impacts. On weight loss alone, some studies suggest that people have mixed results. Studies suggest that ongoing compliance on the drugs are mixed, and that most people regain the pounds they lost. Studies show populations that are quickly stopping usage or stopping and starting. Admittedly, some of that could be related to current high costs. But other studies are more positive. A new study by Epic Research found that 56% of semaglutide, 52% of liraglutide, another GLP-1, and 55% of tirzepatide patients kept the weight off or lost additional weight after stopping GLP-1 use. The study tracked 188,722 patients who stopped taking the drugs after at least 90 days of use for treatment of obesity and had an initial weight loss of 5+ pounds. complete weight loss regains occurred in 23% of semaglutide, 21% of tirzepatide, and 27% of liraglutide users at 24 months. So that is a fairly good record of maintaining weight loss overall, and combined with price concessions, could usher greater adoption of GLP-1s over time. This could lead to greater acceptance of expansion of weight loss drugs in government programs. But no studies are showing immediate or short-term reductions in overall healthcare costs, at least in year one. Some speculate that longer-term savings will be seen to help deal with the obesity epidemic in America and the long-term effects in healthcare costs. So what are current costs for GLP-1s? All GLP-1s right now are brands, and a monthly dose is $900 to $1,350. PBMs may receive substantial rebates from the brand drug makers for good placement or inclusion on their formularies, but they largely do not get passed fully through, if at all, to the consumer at the point of sale. These rebates that go to PBMs and in some part later to employer groups and health plans are between 40% and 60% according to latest estimates. That puts the net price at $360 to $810 a month. But because of the rebate not being passed through in whole or part to the consumer at the point of sale, a monthly cost with insurance could still be in the hundreds of dollars, out of reach for many Americans. A KFF poll finds that most GLP-1 users say their insurance covered at least some of the cost, but over half, 56%, say these drugs were difficult to afford, including 1 in 4 who say they were very difficult to afford. About a quarter, 27%, of GLP-1 users report having insurance but paying the whole cost of the medication themselves. Again, a good part of the difficulty revolves around the rebate not getting passed through in full, as well as the overall high price. A Peterson KFF Health Systems Tracker study finds that a month's supply of Ozempic in other developed countries is $70 to $200. Wegovy is about $300 a month. Mounjaro is $300 to $450 a month. Note that coverage for weight loss in other developed countries can be limited due to restrictive formulary approaches, and obesity rates in these countries is about half what it is in the United States. Mounjaro also appears less available in some developed countries. I would also note that Novo Nordisk is busy reducing prices for cash pay customers because it is being outcompeted in the GLP-1 market by Eli Lilly. With that, we will take our first break, and when we come back, I will get into price concessions that cleared the way for the new models and GLP-1 access in Medicare and Medicaid. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking drug price reform once again, the push for better access for GLP-1 weight loss drugs, and a bit on the MFN models for drug prices in Medicare and Medicaid that were also announced. As I said, the president has wrested concessions from the GLP-1 brand drug makers, along with other brand drug makers more broadly. Appearing with representatives of Eli Lilly and Novo Nordisk, President Trump personally announced lower prices for self-pay customers for GLP-1s and some other drugs. In addition, Medicare will cover GLP-1 semaglutide and tirzepatide at much lower prices, and this appears true for chronic conditions, these conditions with underlying obesity, and apparently obesity alone as well. Until now, neither of these two popular drugs have been covered by Medicare for weight loss and only rarely by Medicaid, Trump said during a press conference in the Oval Office. That ends starting today. This will improve the health of millions and millions of Americans, he said. Medicare will pay $245 for semaglutide and tirzepatide, with $50 copays for medicine for enrollees in Medicare. As well, in 2026, doses of Novo Nordisk and Eli Lilly's blockbuster drugs for patients without insurance will be priced at $350 through Trump RX for a month's supply. Starter doses will be as low as $149 per month. They are currently well over $1,000 per month on a list basis. Starting doses of new pill versions of treatments that should come out shortly will cost $149 a month. Let's now get back to the president's weight loss model for Medicaid and Medicare that he announced. The president has introduced a proposed GLP-1 weight loss coverage model. The better approaches to lifestyle and nutrition for comprehensive health balance model does a number of critical things to carry through on previous announcements by the president, including extending GLP-1s in Medicare to obesity alone, not tied to another disease state, and reducing overall prices and copays dramatically in the program. Under the model, the Centers for Medicare and Medicaid Services, or CMS, negotiates directly with pharmaceutical manufacturers for lower net prices and standardized coverage terms. Negotiation areas include guaranteed net pricing and potential out-of-pocket limits for beneficiaries, standardized coverage criteria, and evidence-based lifestyle support offerings. The balance model will launch in Medicaid as early as May 2026 and in Medicare Part D in January 2027. Participation will be voluntary for manufacturers, states, and plans. Manufacturers, states, and Part D plans need to apply by January 8, 2026, which has already passed. Both Novo and Eli are expected to participate. I would expect many MA plans would join the fold as well. While covering GLP-1s carries some financial exposure, it could also be a source of competitive advantage in MA. Standalone Part D participation, though, could be a somewhat different story given the precarious nature of the program, given passage of significant cost-sharing reduction via the Inflation Reduction Act of 2022. I expect some, but not all states will participate in Medicaid. The balance model goes hand in hand with three other models recently introduced by CMS that would tie the prices Medicare, Part B and Part D, and Medicaid pay for medicines to what is paid in foreign countries, essentially most favored nation pricing, or MFN. The global benchmark for efficient drug pricing model, or the GLOBE model, would cover Part B drugs. A second mandatory initiative called Guarding U.S. Medicare Against Rising Drug Costs model, or the GUARD model, would cover Part D drugs. These both establish most favored nation pricing in Medicare. The generating cost reductions for U.S. Medicaid model, or the generous model, would establish most favored nation pricing in Medicaid. Here are some more specifics on the GLP-1 balance model for Medicare and Medicaid. CMS may adjust capitated payment rates for obesity and increase the government reinsurance for drug fills. Final details will be announced ahead of the 2027 Part D bid process. Earlier, Trump has announced that copays would not exceed $50 per month in Medicare for GLP-1s. It is anticipated that existing users of GLP-1s in Medicaid and Medicare for approved disease states will benefit. not just new users for obesity alone. Lower costs for drugs will be via a prescribed rebate from manufacturers to Part D plans. To bridge to 2027 in Part D, there will be a new GLP-1 payment demonstration beginning in July 2026. This will operate outside of Part D, and plans will not carry risk for eligible GLP-1 products furnished under this 6-month demonstration. How does Trump justify the major expansion of coverage and the about face on the GLP-1 issue? In essence, the Trump administration argues for the program in the following ways. Extension of GLP-1 coverage promises huge savings down the road as obesity leads to new or the exacerbation of chronic disease states. And the program will not cost Medicare anything, as savings from lowering costs on current GLP-1 prescriptions will pay for the expansion to obesity alone. The arguments are not without merit, but the financial picture likely will be more complicated than this. I would argue there is a high probability of near-term costs before some savings are seen in the long term. But that could still mean healthier lives for so many seniors and disabled in Medicare. While Medicare and Medicaid's finances are precarious at best, the major win by Trump of getting lower drug prices overall on GLP-1s and more perhaps justifies the immediate investment in GLP-1 weight loss drug expansion. The drugs have captured the nation's attention, which could be a good thing for health over time. With that, we will take our second break, and when we come back, I will get into details on the most favored nation pricing models. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking drug price reform once again, the push for better access for GLP-1 weight loss drugs, and a bit on the most favored nation pricing models for drug prices in Medicare and Medicaid. Let's move on to some details about the 3 MFN models I began talking about a little while ago. As I said earlier on in Trump 47, the president issued an executive order that said he would introduce most favored nation or MFN pricing. He tried to do this in a small way in Trump 45, but the Biden administration pulled back on it. In part, it was not well thought out by Trump at the time, and it came out at the tail end of his administration. The proposals here for models to test MFN are much more thorough. At least for now, MFN is limited to Medicare and Medicaid. The Centers for Medicare and Medicaid Services announced 3 models that would tie the prices of Medicaid drugs, as well as Medicare Part B and Part D drugs, to what is paid in foreign countries, essentially MFN. I would note that federal and state supplemental rebates in Medicaid are already very generous, meaning MFN and Medicaid may not amount to much, if any, savings. Here are the specifics on the 3 models. The generating cost reductions for U.S. Medicaid model, or generous model, would establish MFN in Medicaid. Generous would run in Medicaid from calendar years 2026 to 2030. It will cover all drugs in Medicaid in all populations and states that participate, and for drugs of participating brand manufacturers. The MFN is based on 8 developed world countries' prices. The MFN price in America will be the second lowest country-specific manufacturer-reported net price, adjusted by gross domestic product per capita at purchasing power parity. Without getting into too much details, the adjustment seeks to recognize differences in standards of living and purchasing power of different currencies from country to country. So the final MFN price will not exactly equal those of other countries. Drugs that are part of the model will have standardized coverage criteria in all state Medicaid programs that participate. The global benchmark for efficient drug pricing model, or GLOBE model, will cover Part B Medicare drugs. It is mandatory for drug makers participating in Medicare Part B. The model will run from October 1, 2026 to September 30, 2031, with rebate invoicing and reconciliation continuing into 2033. The model will cover about 25% of all Medicare beneficiaries using Part B drugs, mainly cancer drugs and physician-administered or infused drugs. Only certain drugs are covered from 7 USP therapeutic categories. The model excludes drugs with annual Part B spending below $100 million and drugs subject to CMS negotiated maximum fair prices. Most importantly, the 20% cost sharing in both traditional Medicare fee-for-service and Medicare Advantage will be based on the final net cost post-rebates. This is a huge victory for embattled consumers with cancer and other high-cost drugs. The agency estimates that the Part B model will save $11.9 billion in net spending over 7 years. The Guarding U.S. Medicare Against Rising Drug Cost models, or the GUARD model, would cover Part D drugs. It is mandatory for drug makers participating in Part D. The model will run from January 1, 2027 to December 31, 2031, with rebate invoicing and reconciliation continuing into 2033. The model will cover about 25% of all Medicare beneficiaries using Part D drugs, usually retail drugs picked up at the drugstore. Only certain drugs in 17 USP therapeutic classes will be included in the model. It excludes drugs with annual Part D spending below $69 million and drugs subject to CMS negotiated maximum fair prices. For both GLOBE and GUARD, there will be 19 developed world countries on which the MFN pricing is based. The 8 countries in the generous Medicaid model are a subset of the GLOBE GUARD 19 countries. MFN for these models will be the higher of 2 benchmarks. The first is using pricing data available to CMS from public and proprietary sources to determine the lowest per unit GDP, PPP, or purchasing power parity country-level price. In essence, this is the lowest international price from commercially available data sources. The second is using pricing data calculated and voluntarily reported by eligible manufacturers to CMS to determine the across-country volume-weighted average GDP, PPP, adjusted net price per HCPCS billing unit. In essence, this is the average international price. Determining these 2 different pricing mechanisms is not well detailed, but the average international price is likely higher than the lowest international price. With that, we will take our last break, and when we return, we will discuss the controversy over MFN pricing, its impacts on innovation, and 2 types of approaches in MFN that can be used. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking drug price reform once again, the push for better access for GLP-1 weight loss drugs, and a bit on the MFN models for drug prices in Medicare and Medicaid. We're now going to get into the controversy over MFN pricing, its impact on innovation, and two types of approaches that could be used. The announcement of MFN by President Trump has focused light on what the policy would do to innovation in the big pharma brand drug manufacturing sector. What do proponents of MFN say in general? Well, they argue that the rest of the free world is free riding on Americans, which pay the lion's share of profits, some 70%, for big pharma due to excessively high prices for innovator drugs in America compared to what citizens in other developed countries pay. They say brand drug makers have the highest profit margins in the healthcare sector, often 20% per year, and are excessive. The arguments have merit, and the arguments seem to already be helping change things. The president has won at least one concession where prices in the UK now will rise on some drugs, and some drug makers appear to be introducing higher prices in foreign markets, anticipating a change in America's approach. Some foreign countries are planning for greater budgets on brand drugs for future drugs as well. In proponents' minds, it is possible to give savings to Americans now and force up prices somewhat abroad, some on existing drugs and a great deal on future ones. What do opponents of MFN say in general? Well, opponents, including the brand drug makers, argue that innovation will be stifled under MFN as research and development investment will evaporate if price falls dramatically in the U.S. They also say it would be unfair to brand makers who have relied on American prices to recoup investment in innovation on existing drugs. As well, opponents argue that Americans have much broader access to innovator drugs than in other developed healthcare systems. I am not sure this is truly the case given high prices a major bar to access, but fair enough. Last, they argue it is very unlikely existing drug pricing will rise in other nations. They question as well how much that would occur on future drugs. But there is a more nuanced debate on MFN as well. The arguments from proponents and opponents of most favored nation pricing you just heard were on the MFN pricing concept in general, applying MFN in America to existing drugs as well as new ones in the future. The nuance is, could there be a middle ground? Prospective MFN, which applies most favored nation pricing only to future drugs in the market, but does not do so to existing ones, which would be retrospective MFN. The conservative Paragon Institute, which holds great sway within the Trump administration, argues that a prospective, not retrospective, MFN strategy should be adopted. Paragon argues that applying MFN pricing retrospectively to drugs in the U.S. would likely not mean higher prices abroad, as current drug prices have already been negotiated, and innovation would plummet. As well, Paragon says an aggressive retrospective approach could cede future innovation research to China, which is not hobbled by free market dynamics. Paragon argues prospective negotiations would mean higher prices in the future abroad and other developed countries picking up their fair share of innovation costs. This is because leverage between brand drug makers and foreign healthcare systems would suddenly exist. No access to new novel drugs if the countries hold out for prices that are too low. So what is the Trump administration proposing with all that has been announced? Retrospective MFN or prospective MFN? Well, it is confusing. When Trump announced the results of his negotiations with over a dozen brand drug makers, the press releases spoke of America getting most favored nation pricing on future drugs in Medicaid, Medicare, and apparently commercial coverage. That speaks to prospective MFN. At the same time, those announcements also said Medicaid would receive MFN on existing drugs. That is retrospective MFN. The announced generous model for Medicaid gives MFN on existing drugs, so again, that is retrospective MFN. But it would also capture new drugs to the market as well in the 5-year pilot. so prospective MFN2. The Globe and Guard models for Medicare gives MFN on existing drugs too, so again, retrospective MFN, but would also capture new drugs to the market as well in the 5-year pilot, so prospective MFN2. So the reality is that what's been announced is really a combination of both retrospective and prospective MFN. As a proponent of the free market, I don't totally dismiss the idea that innovation could be hampered. But I also know that brand pharma makes the highest margins of any healthcare entity, and businesses tend to reinvent themselves when faced with existential change. Insurers saw this with minimum medical loss ratio mandates. Further, some of the innovation dollars spent are to protect margins and are not game-changing innovation. And it has to be said that even if innovation suffered, lower price has the halo effect of getting needed drugs to many with chronic disease states. Today, some of those with chronic disease states resort to splitting pills or going without their drugs, which has huge implications for their health, morbidity, and mortality. That said, I see the possibility of a combination of prospective MFN to comprehensively reset the worldwide drug pricing table moving forward and phasing in MFN on existing drugs to tackle concerns on retrospective MFN. This could balance innovation fallout and provide needed relief for Americans. In general, I hope the president continues down this course and implements all the far-reaching reforms he has proposed for drug pricing. We desperately need reform in all lines of business, including the employer world. Here is hoping the president also puts together a coherent agenda for healthcare reform generally as well. With that, we will conclude this episode of the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.